Okay, good morning, everybody. We're recording now. We have Dr. Zach Creamer here, our PACU resident, talking about local anesthetic systemic toxicity. Again, anybody on Zoom, make sure you have yourself on mute and throw things in the chat if you'd like to. You want to swipe this control meeting away, or okay. There you go.
Perfect.
Okay.
All right, guys. Thank you. Thank you for having me here today and for letting me, rotate through the PACU and all that kind of stuff. I appreciate it. I'm Zach. For those of you who don't know me, presentation today is going to be on local anesthetic systemic toxicity. I chose this topic because we had a case last week that presented with LAS in the differential. So I thought it would be a good time to bring it up because treatment is very unique. So I want to get started by just telling you about myself. I have no financial disclosures, but always open to them. I grew up in Mount Pleasant, Michigan, dead center of the state for all those who don't know. Went to Fair State for undergrad. Took a year off after undergrad, took a gap year, dealt cards at a casino, just kind of randomly, and then joined the Air Force. I'm currently a captain in the Air Force. I have time that I will owe after I graduate residency. And then after Fair State and after the gap year, I went to Michigan State College of Human Medicine for med school in Grand Rapids for all 4 years. I don't know why. So intermittently, I've just kind of thrown pictures in there. So just as an aside, my dog there, Otis, that's his Halloween costume from last year. His doggy daycare like dressed him up and took photos. So, and then my wife, Alexa, we've been married since 2018. So local anesthetics in general, you're going to want to break these down into two groups. It's going to be esters and amides. Now, when you look at all of them, there's so many local anesthetics. It's hard to keep them straight, but the easiest way to do it is amides. There's an I in amide, and all the local anesthetics that are amides have two I's in them, all of them without. So bupivacaine, lidocaine, ropey, etc. You can see the two I's. That's the easiest way to delineate these two. Esters up at the top include cocaine, benzocaine, tetracaine, stuff that we don't use very often. We don't use esters as much just because one of the metabolites is PABA. It can cause pretty significant allergic reactions. So we just avoid that generally. There are situations where we still do use esters in general. So the basic pharmacology for local anesthetics are weak bases, poorly water soluble, and because of that, they're dispensed as hydrochloride salts with acidic pHs in the range of like 4 to 7-ish. They're protonated at physiologic pH, and then the mechanism is blocking the sodium channels essentially. So they reversibly and frequency dependent block the voltage gated sodium channels. So essentially, if you remember, for action potentials for your neurons to fire, some sodium channels open, sodium comes in, and as soon as more sodium comes in and more channels get activated, it leads to a snowball effect. And then you get this depolarization and you get the action potential. And then that signal is going to be going to the brain, and then you feel pain, etc. So let's talk about the anesthetic potency. There's a lot of factors that can go into it. It correlates with lipid solubility and molecular weight, but it's also affected by nerve fiber size, the type of nerve, if it's myelinated or if it's unmyelinated, the pH of the tissue that you're injecting the local anesthetic into. And then if you're using nerve stimulation, which we typically don't use, APS may sometimes use that for some of the blocks, but not usually. Then these things all affect the local anesthetic potency. So you can see there's a lot of factors to think about, and a lot of like nitpicky things. I don't want to go through any of that stuff. I kind of just want a general overview of what it is, and things that can be applicable to everyone. Another thing that is important to mention, difference between amides and esters. So remember, amides, two I's, it's hepatically metabolized. So if someone with significant liver failure, you're not going to want to use these amides. And then the esters are metabolized in the plasma by pseudocholinesterases, which is also synthesized in the liver. Which you can have a pseudocholinesterase deficiency and affect the metabolism of esters.
Are we muted?
This is also another picture of Otis at doggy daycare, another photo shoot he was in, sticking his tongue out at the camera.
Except for the last one, that's promoted to the Big Brother.
Oh my gosh, I'm so sorry, you guys. Thank you for pausing me. I meant to say that. So Otis is our firstborn. He's 3 years old. As you can see here, it says promoted to Big Brother. So we are expecting March 6th, we're having a baby boy. We're very excited. As an aside, thank you. I appreciate that. Thank you for reminding me as well. Oh, this is like, oh, his it's like a sleeper eye thing, you know, but they put it up because he didn't want it on his eyes. So when we're talking about absorption of local anesthetics, it's important to realize where the local was injected, because different places have different absorption rates. So one of the things that I find most interesting, and I feel like it's not very intuitive, is if you look, so I organize it by highest systemic absorption to the least. It looks like IV is the highest there and subcutaneous is the lowest. Second one's tracheal. So if you're thinking of like AFOI and people are inhaling lidocaine, it's like, oh, no big deal kind of thing. And then you go back to the OR and you inject some lidocaine at induction, they had a block. You can see how all these things really add up, especially if you're injecting or topicalizing in an area where there's a lot of vasculature, which will allow for increased systemic absorption. So what are some things that'll decrease the absorption? Vasoconstrictors. If you just add a little bit of epi, it's particularly useful for local anesthetics with shorter durations like lidocaine. It also limits the toxicity because it decreases the absorption. So IV, initially there's a rapid uptake and to the highly perfused organs, then it's slowly redistributed to moderately perfused organs. So just in general, just realize that those different areas have different absorption capabilities. So it's not all the same. So let's talk about some risk factors for last. Before I get to that, I gotta talk about the pictures each time before I forget. There's Otis enjoying his snow, and it looks like my wife and Otis, maybe like a holiday at, it looks like her parents' place. But risk factors for last include the block site, which we just talked about, the local anesthetic dose, use of bupivacaine, and I'll talk about that in a little bit here, and this other local anesthetic that I've never seen used. Extremes of age, so greater than 70, and then pre-existing cardiac, renal, or hepatic dysfunction. So toxicity. Let's just think in general, like if you have a toxicity of a substance, really you're going to want to like draw a lab and see how far overdose this patient is. For LAS, you don't do that. And the reason that you don't do that is because it takes a while, number one. And two, they don't guide or change the treatment. If we suspect this, it can get really bad really fast. So you would just treat it without looking for a level. So that's not something we do. I just wanted to mention that briefly. And then if we go through the effects of local anesthetics and a related dose-dependent effect, we can think of like a regular 1 to 5 dose of analgesia. 5 to 10, you probably get some circumoral numbness, some ringing in the ears, muscle twitching, can cause hypotension, and then decrease automaticity of the heart as well. 10 to 15, you start getting up to like seizures, unconsciousness, I think 5 to 10 is probably slightly common, especially immediately after induction. A lot of the times we use higher doses of lidocaine to blunt the sympathetic stimulation response of de-yelling someone. But they're asleep, so we can't tell those things. It's not common to have anything else, obviously, otherwise we'd hear about laughs all the time. So 10 to 15, the seizures and unconsciousness, 15 to 25, apnea, coma, and then eventually cardiovascular collapse and depression. So the CV to CNS ratio is the dose required to produce arrhythmias versus to produce seizures. So if it's lower, there's a reduced margin of safety. The problem is that you don't really get a warning. It kind of just happens. So you have to suspect it when it's possible. So here's some signs and symptoms. In an awake patient, it's easier, obviously, because you can ask them these things. Circumoral numbness, tongue numbness, or circumoral numbness, yeah, tongue paresthesias as well, ringing in the ears, blurry vision, and then you kind of get into this excitation phase in CNS. So one of the things is muscle twitching. People are just uncomfortable, kind of restless in bed, and then they have this sense of like impending doom, like immediately after adenosine injection, you know, that kind of thing. And then once you see those things, then it's all downhill from there, because then you get into CNS depression, leads to drowsiness, unconsciousness. You start getting muscle twitching, then you get full-blown tonic-clonic seizures, for which you treat as usual with benzos. For a potent and highly lipid-soluble local anesthetic, they produce seizures at lower blood concentrations. You just got to be more careful for that. And then bupivacaine across the board is very well known for its increased risk for myocardial or for cardiotoxicity, and is most commonly associated with seizures. However, we use it all the time, so just be wary of that. What else? Cardiology-wise, let's talk about that. So basically, if you're thinking about neurons and the action potential that I described, the muscle and the heart, it's a similar thing, different sort of channels, but the heart uses sodium channels as well. So you can get the decreased automaticity of the heart. It's the electrical system that you're interfering with. So the phase 4 of a depolarization of a heart muscle, it depends on sodium influx, and if we block that with local anesthetic, that is not a good time. So toxicity with cardiology, bupivacaine is most well documented, followed by ropi, followed by lido, all amides, as you can see with the 2 eyes. What you see first is PR and QRS prolongation, and then you start seeing some re-entry arrhythmias. If you use calcium channel blockers, beta blockers, and any other nodal agents, it may increase the risk of toxicity of the heart. Pregnancy, hypoxemia, respiratory acidosis are all predisposing factors as well. And then at high concentrations, you get smooth muscle relaxation and vasodilation causing hypotension. Except for cocaine, squeezes everything. I don't think we can get that on formulary though. That's a joke. Prevention. So only you can prevent laughs. You have to use the lowest effective dose. You just have to be safe about things. I think that generally it's common to think like, oh, how about some lidocaine? How about a lidocaine patch, you know, because someone's having pain, or it's just thought of as kind of nonchalant when there are significant risks associated with local anesthetic. So we need to be mindful of that. Incremental injections, frequent aspiration, having patients hooked up to monitors while you're doing it so you can see if there's a change in heart rate if you did inject intravascularly. And then, of course, ultrasound. So here's the big slide. Treatment. Number 1, just like anything else, when something's bad happening, stop doing it. So stop the injection or the infusion. The second part of the treatment is going to get intralipid. This is the treatment, the only treatment for LAS. Well, we have the block heart here, actually. Perfect. So if you just, I think it's 1, 2, 3, 4, enter. really secure. The last drawer, always a bottom drawer, and it looks like propofol. So it looks like this. All you need is this and the Laris tubing, and you're good to go. There are two carts, two black carts, one in PACU, which goes right around the corner, and then there's one in pre-op holding as well. It's where APS hangs out in like slots 18, 19, 20, I think it is. They have a block cart as well, and there'll always be interlipid bottom drawer. 1, 2, 3, 4, enter. If you need to find it, those are the only two places that it's rarely available here in regards to the location of you guys compared to other people. So while we're stabilizing, this is a big deal. So we called for help. We got the interlipid, and we just get it going. It doesn't matter how much, you just need to get it going right away. Essentially, is the biggest thing. And while you're doing that, next step is arranging for cardiopulmonary bypass. You can see that it can go downhill very, very, very fast. So it's not an ideal situation to be in. Airway management, standard things, you know, you're going to want 100% oxygen. You're going to want to prevent hypoxemia, hypercarbia, and acidosis. So things are going to worsen last. For seizures, if you see seizures, it's the same as previous, or same as like when you see a seizure. Otherwise, it's going to be benzos. But what's interesting is you're not going to want to use larger doses of propofol to suppress seizures if they're refractory to benzos. And that's largely because intralipid is a lot of fat as well as propofol. Then the arrhythmias come. So for the arrhythmias, you're going to want to just follow ACS protocol. There's a couple of things that are different though. Epinephrine is reduced, so it's less than 1 mic per kg. You're also going to want to avoid common drugs like vasopressin, calcium channel blockers, beta blockers, local anesthetics, things that disrupt the automaticity of the heart. And then amiodarone is going to be your first line antiarrhythmic agent. So when it comes to intralipid, like I said, biggest thing is get it running. It doesn't matter how much you're giving, you just need to get it going as fast as possible. Generally, what people kind of think of is if a person is greater than 70 kilos, they can get 100 milligram or 100 ml bolus right away. If they're less than 70, you're going to want to do 1.5. And something to note, 1.5 mLs per kilo. It's not milligrams per kilo. So it's also a little different in that instance, which is why generally people don't try to memorize that, because putting 1.5 milligrams per kg is going to be very different from 1.5 mLs per kg. So generally, if you're over 70 kilos, 100 milliliter bolus, and then you can look up the infusion later. Or if they're less than 70, 1.5, and then you can look up what it is, mLs per kg, followed by the infusion, which you can start later. Biggest thing is getting it into the patient. And if they're unresponsive to lipid emulsion and ACLS, then you go to cardiopulmonary bypass. So let's talk about a case that we had here last week, unfortunately. It was in slot 12, I think. It was an 85-year-old woman. She was an ASA2. She had a left total knee. So she in pre-op had an adductor canal block. And then intra-op, she had a spinal. Right before they left the OR, she had an additional intra-articular injection by the surgical team. When she came back to us, I think it was thought that the monitors were not working, because when we hooked up the patient to the monitor, the heart rate wasn't reading, blood pressure wasn't reading. So it's not ideal. So we switched the cords, we switched the tram and felt her pulse, and her pulse was very faint. Heart rate was initially undetectable, and we switched the cord, it read 30. So obviously not ideal. So if we're going through and looking at the local anesthetic, so when we think of ortho, I mean, local anesthetic is going to come into your mind because there's always blocks or spinals, etc. with ortho. So if it's an ortho patient coming with some of these signs and symptoms, last is going to be close to the top of the differential. So at 9:20, she got 0.25% of BUP, and this was for the adductor block. At 9:44, that's when she was in room getting the spinal, 1.7 mLs or 0.75% BUP. Then at 12:06, it was documented in centricity that surgical dressing was complete. Something that we don't always document that we need to be way better at documenting, and I'm referring to like anesthesia, residence CRNAs, etc., is the amount of local given in a procedure. Most of the time, it's like the surgical tech kind of fills a syringe at the beginning of the case, and then the surgeon just kind of asks for local, maybe not knowing what the concentration is, etc. Again, more laissez-faire kind of with these local anesthetics than we need to be. So looking back, it wasn't documented how much intra-articular or the formulation of what local anesthetic was injected or the concentration. All of that was missing in this 1206 in centricity. So when we're looking back and trying to figure out what's going on, we don't see that. The surgical team said, yes, we did inject 0.5% bupi, 20 mils just before coming out. So 14 minutes later, they got here, and that's when heart rate was undetectable, pulse was present but really faint, hypotensive. About 8 minutes later, while we're kind of calling the necessary people and getting her hooked up to everything in the bay, she became unresponsive. We slapped on some pads because as soon as Dr. Young, who was my faculty at the time, got there, she noticed a sinus pause for about 6 seconds on the monitor. So we were about to start ACLS. At that, it was right before that, probably at 12:20-ish, that we injected glyco 0.4 and ephedrine 10 when heart rate and blood pressure were not reading on the monitor. And then shortly after Dr. Young got there, APS was at bedside. Intralipid was also at bedside. However, APS was unconvinced at the time that this was last in relation to the regional block, at least, because of the timing, because it was about 3 hours ago since they had done their adductor canal block. Shortly after that, patient became responsive, responded to our drugs, blood pressure normalized, heart rate normalized. She became responsive to commands. At this point, she was alert enough to ask questions. She denied tinnitus and perioral numbness, so blast became lower on the differential. We kept intralipid at bedside in case she were to absorb any more of the local anesthetic that was injected at the end of the case. But thankfully, we didn't have any other complications. Until 12:55 came around, she began having muscle twitches on the left side of her face. So now at this point, we had cardiovascular collapse, essentially. I mean, the heart rate was undetectable, then it was like 30. Now we have neuro symptoms. We're starting to have muscle twitching. And when we went to go ask the patient, like, what's going on, she couldn't explain what she was feeling. And she just kind of looked restless in bed. Reconsulted APS. At this point, her vitals were stable. They were unconvinced it was last, given that she had resolution of her symptoms and was now hemodynamically stable. So this,
Sorry to interrupt. The
Yeah.
only thing you guys did give was the
that's it.
epi and glyco.
Mhm.
Okay.
Glyco and ephedrine, yeah.
Okay.
So this little table here, I can show you how to get to it. You probably don't really need to know how to get to it or whatever, but this is what we have access to on our anesthesia website. It's a LAST calculator. We use it all the time in the OR. When generally it's nice, like if you know that patients are going to be getting local at the end, to have this all pulled up and ready, because sometimes the surgeon asks how much local they can give, and this table gives you the exact amount. So what happens is I'll go to it after I'm done with this presentation, just because I don't want to exit out and that sort of thing. But if you go to it, it's essentially blank, and it looks kind of like you just have a blank weight there. You put in the patient's weight, and then you can put in different formulations, different medications, and then it shows you exactly the toxic dose in mLs, as well as in the volume administered, and then it shows you how close they are to last. So something that is also not the best is that you're supposed to use ideal body weight, which is usually significantly less than a patient's body weight, especially here. So this patient, 85-year-old woman, her actual body weight's 95 kilos. her ideal body weight 62. If you go to this calculator, I cut it off, but right here in like bold letters is use ideal body weight unless your attending has a different preference for some specific reason. So we should always be using the ideal body weight, which would be 62 kilos for her. So let's go in, type in what she got. And if you type that in, she got 159% of what she was supposed to. Was it less? Well, allegedly, I mean, we can't confirm it, but it could have been. Another thing that kind of gave us pause with last is that textbooks preach over and over that you get cardiovascular symptoms followed by neural symptoms. Opposite, neural symptoms followed by cardiovascular. And in her case, it was opposite. So she had cardiovascular first and CNS second. When we went to UpToDate to go look into this a little bit after the patient was stabilized, it's actually quite common to only have neural symptoms. So 45% of the time, patients only have CNS symptoms. 44% they have both, and 11% only cardiovascular. And then cardiovascular wise, the most common presentation is bradycardia and hypotensive shock, which our patient experienced. So this is the intralipid. I showed you the bottom drawer. It looks like a propofol. There's really no, okay, the adverse effects are like if you bolus way too much too fast, you can get some hypotension, and then some of the glycerol in that can interfere with lab values if you were to go get your triglycerides drawn afterwards. So it's not toxic. And now you all know where intralipid is. Oh, this is a wedding photo. This is my sister all the way over here, my wife, and then my parents. And finally, my references and my favorite picture of my dog.
What kind of dog is it?
It's a mini Australian Shepherd. He's 3 years now. Yeah.
So,
Otis. Yeah.
so do you think as part of that, like that calculation that you've shown, I mean, it would be probably a good safety check when you're in there, like after EPS does their thing, and you know, we walk into the room and be like, hey, if you're guys going to do lidocaine at the end of this case, this is the only dose that you get to do. This is what you have left.
Yeah.
Like that would be a good safety check.
Absolutely. And more often than not, that's how it works. More often than not, when we get in, especially for ortho, they're generally pretty good about it because they inject so much local. At the beginning of the case, it's always during the timeout when we're going through the important things, the surgeon will say, I'm going to inject local at the end. Tell me how much is safe for the patient. So then during the whole case, you have time to go on that calculator and look it up. And then at the end, you tell them, just get the calculator up and show them or tell them or whatever. Sometimes that's not the case though. Yeah.
Patient, but I have a question.
Yeah.
So, because you said there's a time frame. When this class usually starts?
It's usually about 15-20 minutes after injection.
Oh,
Yeah, which fit in line perfectly with when she had the periarticular injection at the end of the case. Uh-huh. No, it could be because they're still infusing it with the, yeah,
Or, and, you know, just.
very well could be. Yeah.
Is she going to be able to start?
But I think in the next 2 days, I think it's.
Thank you.
Probably.
Yeah, of course, no problem. Thank you guys.
This is great. Thank you.
Yeah.
If you, outside of there, we'll see if anybody threw questions in the chat. No, maybe.
Oh, no.
Oh, sorry.
Yeah.
Okay,
All right. Thank you.
awesome. Thank you. We appreciate it.
Of course.
Little pictures.
At the end, I didn't see the very end of it.
What happened?
She didn't up Tuesday.
She was actually more with Kelly.
Wow. So I have a question. You said to just go ahead and start the lipids?
Yeah.
Can they be free flow? Okay. So that was part of the drip. Did you guys end up starting the
We
lipids?
did, and we were so close to, except APS was so convinced that it wasn't.
Thanks, guys.
I'm from a different facility, but we ran lipids, I mean, that was like a thing. So since there's really nothing like